Hello, and welcome to the latest installment of the Health Storytelling Author Q&A for this semester and academic year. I'm Maryn McKenna. I'm a journalist and author and senior fellow in the Center for the Study of Human Health at Emory University. I'm the curator of this series, which makes me your host as we undertake our latest set of author conversations. In a moment, I'll introduce you to my guest, Eram Alam, who's an associate professor of the history of science at Harvard University and the author of the just published book, The Care of Foreigners: How Immigrant Physicians Transformed U.S. Healthcare. But first, let me tell you about this series. At least once per month during the academic year, we invite writers whose journalistic or academic books examine health, the science and history of health, and health's intersection with society. This series of conversations is sponsored by the Emory Center for the Study of Human Health, along with an array of fantastic co-sponsors. This autumn, those have been the Georgia Center for the Book, a local affiliate of the Library of Congress that stages very frequent public conversations with authors, illustrators, poets, and others to bring the news of new books to the public. And Emory's Center for Public Scholarship and Engagement, which creates opportunities for faculty, staff, and students to share ideas with local and global audiences. And the center's new Ideas Festival Emory, which launched in September a year ago on Emory's Oxford campus and just returned last month with an amazing lineup of speakers. Let me tell you who else has been appearing in this series, which is live streamed on YouTube, LinkedIn, Facebook, and Instagram, and archived on YouTube for several years now. The authors who've been appearing this semester are, tonight, as you've heard, Eram Alam, PhD, with The Care of Foreigners: How Immigrant Physicians Changed U.S. Healthcare, which was published in October by Johns Hopkins University Press. Last month, we heard from star Julia Vartan with The Stronger Sex, which was published in July by Seal Press and imprinted Hachette Books. And we began the season with a conversation with Jenny Aaron Smith about her book, Valley of Forgetting: Alzheimer's Families and the Search for a Cure, which was published in April by Riverhead. One final note. This is a live event. You can interact with us, and we encourage you to do that. If you want to ask a question, please comment on any of the platforms where you're watching us. Our producer, Stefan Kaplan of Spin It Social, will make sure we see what you've said. Do note, I'll turn to your questions in the second half of this hour-long conversation, but you can put your questions into the comment boxes at any time. We will see them. Now, let's turn to our book and guest. Eram Alam is a scholar specializing in the history of medicine with a particular emphasis on globalization, race, migration, and health during the 20th century. She has been concerned with an enduring puzzle: how the United States should organize its healthcare system given that it trains fewer healthcare providers than Americans need to get good care. For more than 50 years, the answer to that conundrum has been importing physicians who were born and trained somewhere else. That legal maneuver, codified in law in 1965, was intended as a temporary measure, but through use, it became permanent. Now, 1/4 of the physician labor force in the U.S. is foreign-born, and that doesn't count the nurses, physician assistants, and home health aides who also come from outside the country. But political challenges to immigration policy that are being carried out in the U.S. right now may bring more scrutiny to that program, with complex consequences for U.S. medical care that these immigrants deliver, and also for the less well-resourced societies from which they come. Dr. Alam is also a co-editor of the 2024 collection Ordering the Human, which was published by Columbia University Press, which explored how racial categorization shifts with political and clinical needs. And she's at work on a new book on international medical tourism. Eram, welcome to this series.
Thank you so much. I'm so excited to be here, Mary.
I'm really thrilled that you were able to be available. So I always ask people to start with how they came to the work that we're talking about. So let's do that for you. Who are you? How did you come to be who you are professionally and academically? And what drew you to this book?
Yeah, thank you so much for that. So I, as you said, am a historian of medicine, and I started off in graduate school thinking about racial health disparities, and I was really interested in the fact that these exist, and often that they're concentrated in under-resourced communities. And so I kept reading the literature, and there's public health literature that points to the fact that there are racial health disparities. And I just was asking this question, but who's actually working in these communities? Because I wasn't getting a full picture of what the infrastructure was like. So, you just keep getting, yes, rates of diabetes are greater, rates of, heart disease are greater. And so I started to investigate that question, and I realized that it was immigrant physicians who were doing the bulk of the labor in these communities and were providing this necessary care there.
So was this, let me start the question again. How did you come to understand where these physicians had immigrated from? When did you start to understand the full picture of how they had come to the communities where they were working?
Yeah, so just in, I can give you the kind of, I joke around and I say growing up, so I'm South Asian, my parents are from India, and my parents came with this 1965 immigration movement, but they were engineers. My dad was an engineer, he was not a physician, but there was always this assumption that was made about the fact that I was a doctor, or I was the child of a doctor. And so there's kind of this easy association that every time I would go to the doctor, they'd all ask me, of course you're a physician, right? And I'd say, no, not even close. Much to my mother's disappointment, not even close. I'm a historian. And so, I just thinking about why is it that it's so easy for people to make this connection in everyday conversation between somebody who looks like me and this professional status of a physician. And so in doing that kind of, sitting with one's own life and then thinking with this question of health disparities, it kind of brought me to this answer, which is that these are immigrant physicians who are predominantly coming from post-colonial Asian nations, with India, Pakistan, and the Philippines as the largest sending countries. And that was the case in 1965, and it continues to be the case today.
In your own family, was there discussion of that immigration scheme that allowed your parents to come? Was that date of 1965 significant to you?
No, it actually wasn't. We never talked about it. The ironies of in some ways, we say you do research every time you do research, but no, there was no conversation around how they were able to come and what that was like at all. And so, yeah, this again led me to this huge curiosity around how is it that at this time there was this influx, something changed. And I really was interested in figuring out what was it politically that changed during this time that facilitated this huge migratory regime to get established in the United States.
And in the book, you do such a lovely job, I think, as a reader who knew nothing about this history, of unpicking the threads that sort of wove together to make that legislative act possible. The lingering shadow of World War II, and as you just referenced, the shadow of colonialism in South Asia, the pressure of the Cold War and the desire to exert soft power in a friendly way to nations that might have shifted one way or another. Talk about that, about the historical backdrop before we get to 1965.
Yeah, so this was a really complex political moment. So emerging out of World War II, the United States is the superpower, and one of the ways that it needs to exert its authority in the world is, as you said, through this soft power. So science and medicine become these really important arenas, these political arenas for diplomacy, and ways of sharing that kind of information signals, oh, you're a friend, not a foe. So you have also at this period of time these post-colonial Asian and African nations that are just entering the world stage. And there's this real fear that they're going to lean potentially more communist, especially because they're often not wealthy. And so one of the really important reasons why immigration was changed during this period of time was because the United States had an extremely restrictive and racist immigration policy that was on the books. The most comprehensive policy was this 1924 Act, which had a national origins. It was a National Origins Act, which limited people from South and Eastern Europe from coming. There was a quota, and there was an Asian Exclusion Act, which is exactly what it sounds like. So lawmakers understood that, well, we can't on the one hand say to these countries, hey, we want to be your friends, come hang out with us, join our capitalist sphere of influence, yet we have this immigration policy that disallows you from actually entering physically into the United States. So it was really urgent for them to remedy this so that they could signal in this way of soft power that, hey, we actually are welcome and we want you to come. So geopolitically, that was a lot of the motivation for what instigated this shift in immigration policy. And then on a very domestic level, there was an issue with labor shortages in the country. So post-World War II, you have the baby boom that's happened. You have also people who have a different relationship. There's a lot of political action that's happening in the Black community, in women's health movement. So people are starting to have a different relationship with what health is and access to it, arguing that it should no longer be this luxury good, that it should be something that is a right for everybody. And so more people should have access to it. And then two important pieces of legislation really also shifted this conversation. And one was the Civil Rights Act, of 1964, which desegregated hospital facilities. If anybody wanted to receive any federal reimbursement, they had to desegregate their facilities. So this was huge because in 1965, when Medicare and Medicaid expanded, so Medicare people over 65, Medicaid people who are low income, hospitals wanted that money, physicians wanted that money. And so they were forced to desegregate. And then overnight, you have these, with Medicare and Medicaid, at least 20 to 25 million people who are now able to access healthcare. So all of these things is kind of this perfect storm of stuff that happened where then all of a sudden said, okay, we've changed so much of the healthcare infrastructure, yet we don't actually have the practitioners who are going to be able to provide care. Well, perfect. Let's use immigration and expedite the entry of people who have these certain skills. So scientists, physicians, to quickly come and enter into the US labor force, because then they satisfy two things: this geopolitical motivation where they're able to, the United States is able to say, hey, we welcome you. And you're also providing a particular kind of labor that's in desperate need in this country.
It's fascinating to me how many sort of historical threads end up being knotted together to make this happen. Because as you say, there's the creation of Medicare and Medicaid, so more people are guaranteed medical care. Medical care begins to become more democratized, I suppose. At the same time, it's the post-war years in the United States. That's the years when there begins to be more attention to the food supply, which is one of my topics, and nutrition gets better, and people are living longer, and so there's more people around to be taken care of for longer. But at the same time, and I'm about to reference something that I fear most of the audience will know nothing about, but I am obsessed with it. Decades earlier, there was the reform movement in American education, medical education, represented by the Flexner Report, as it's come down to us for its main author, that sharply reduced medical schools in the United States, reformed medical education, and particularly had a really negative effect on medical education for minoritized people, wiping out many of the Black medical schools that had grown up. And all of that swirls together to make this moment in 1965 possible. It's fascinating to me.
Yeah, no, you're right. This is actually an issue that started, how you identified, in 1910. I mean, even prior to that, in the 1900s, where, these, often in the United States, there were these elite medical men who were trained in Europe, and they were trained in a system where that was actually quite comprehensive, that had medical education that was standardized. It had years of didactic learning in addition to clinical training, in addition to laboratory-based work. That was not the case in the United States. So they often got their training in Europe, came to the United States, looked at the condition of things, and were appalled by what they saw, because you could have people call themselves doctors if they were working in an apprenticeship program. Some people went for 4 months and were able to call themselves physicians. Other people went for 2 years. And so the AMA, the American Medical Association, really got involved at this time and used this platform of kind of occupational closure, of trying to create this standardized profession as this very, very important thing for them to establish some kind of identity. And so they, through a lot of bureaucratic and these kind of institutional mechanisms, essentially ushered in the end of all of this diversity in terms of who could call themselves a practitioner. And they really standardized it so that you had to go to school for 2 years. It's the system that we are familiar with today. So 2 years of like school-based learning, and then you have your clinical training, and then you have your residencies, et cetera. And what that did was it also just eliminated all of these other medical schools, women's medical schools, Black medical schools, because they were not able to reform in the same ways. They didn't have the financial capabilities to be able to expand their facilities, expand hiring, have laboratories next to their classrooms, to actually physically change the infrastructure of medical education. And so the consequence was that they were closed as a result. And you have to remember also, we're in Jim Crow's completely segregated time in the United States. And so Black physicians were very, very rarely allowed to actually enter into medical school. Women, same exact thing. And so you have this narrowing of the profession around this very homogenous white male elite wealthy identity, and a very limited number of them. And so that does this important work, because, as we all know, scarcity is the way of increasing value. Why are diamonds, why are they valuable? Well, because they're not that easy to find. Carbon is carbon. But at the end of the day, so this is what they were doing, is that, how do we create scarcity? How do we close this profession such that we can allow it to rise in prestige and authority within the social sphere? And they succeeded.
It's one of the bitter ironies of this, that the physicians who might have been more likely to work in disadvantaged areas, or might have had family connections to disadvantaged areas, were essentially made not to exist by those actions more than a century ago. Toward the end of the book, you reference a paper that I wrote about recently myself, and I think it's a great analysis about how the closing of those Black medical schools in the years after the Flexner Report have echoes down to the present day, and how many more Black physicians there might be if those schools had still existed. It's a really profound lesson in how actions ripple down through history in ways that are unpredictable. So So when this program was created in the 1960s, was it intended to benefit South Asians, or was that an accident that South Asians were the ones to most benefit from allowing foreign medical graduates?
Yeah, no, it was more, you know, accident is a tricky term. I think, again, to think about this historically, it's a legacy of a history, and that history is that of colonization, of by the British. And so we, to think about this longer legacy. So South Asia, India, was the crown of the British Empire, and they invested a lot in thinking about infrastructure and biomedical infrastructure and establishing that within India. And the legacies of that are that Indian medical education, or a lot of it, especially the most elite medical education, is taught with it's completely Western in its biomedical, it's Western biomedicine, and it's also taught in English. And those things are very, very important in being able to translate these people who are practitioners into these different contexts of the UK, of the United States. And so by the 1960s, there was in the 1940s to the 1960s, there was a huge migration to the UK. And in the 1960s, there were some restrictions that started to happen in the UK. And there was a lot of racial animus that was showing up within the UK scene. And so people started to pivot and to think about the United States as a different kind of option. And so it wasn't necessarily that they were advantaged or explicitly called out for that reason, but it was because of these longer historical legacies. And that's the same thing with the Philippines. The US colonized the Philippines until 1946. One of the things that they did while they were there was to establish medical schools, nursing schools. And so we see the consequences of that within the huge Filipino migrations that have happened with nurses. And the same corollary is happening with physicians because of these longer histories.
I want to remind folks who are watching us, we can see that you are there. Thank you so much. You are welcome to leave us comments at any time. We've already had some fantastic comments from some of our viewers. And I'll just remind you that you can put your comments in at any time. You don't need to wait until the second half, which is when I start to ask them. And I will get to them, I promise. As you can see, some of them have been popped up already. So, Eram, the U.S. perceives that there is a medical drought in particular areas of the country, in particular economic strata. They, at the same time, as you said, American medicine was becoming increasingly sort of was narrowing into a particular stratum of society, white, male, wealthy. So the foreign medical graduates from South Asia are available, and they're sent to particular places. How did that work?
Yeah, so often what would happen was that in U.S. embassies abroad, so there are U.S. information offices that were spread all throughout South Asia, and this was a remnant of Cold War soft diplomacy, kind of the ways the propaganda traveled. And so in these U.S. information offices, there was people, hospitals were able to advertise, oh, look, we have an opening for this position here, and we'll help you come to the United States. We'll pay for your airfare if you come here. And often the places that would advertise those were places that were under-resourced because they were trying to draw and attract physicians. So that was one route. Another is that part of the ways that people were able to come, their visa were structured such that they were allowed to come if they worked in shortage area communities for a certain period of time. So it's essentially this kind of probationary visa structure that if you work here, then after that, after you've completed a certain number of years of service, you can move into another place. But it's through these kinds of structures that migration was really coordinated such that immigrant physicians went to specific hospitals and specific under-resourced communities. So it wasn't like they rarely had a lot of freedom of choice. So it was where are the openings? The openings are often in under-resourced communities, community hospitals, public hospitals, safety net hospitals, rural areas. And then on top of that, the ways that the actual legal entry, the visa provisions, structure it such that you have to work in a particular shortage area community if you're going to come here. And so that creates this kind of stream and the stratification of the labor force where US trained physicians are going to the big cities, they're going to well-resourced communities, and immigrant physicians are going everywhere else.
And what was their integration like? You can see throughout the book that there are people whom you spoke to, whether you use their real names or not, but there are quotations from people who were part of this program. Was it seamless or was it difficult?
No, I think it's very complicated, especially at the beginning. I mean, again, to come back to that 1965 moment. And so we just imagine the clinical space where all of a sudden you have white patients and Black patients in the same space. You have white physicians who are still there. And then all of a sudden you have the insertion of the immigrant physician, who, especially at the beginning, they're generally South Asian men who are coming and working in these spaces. And so that is a very complicated dynamic. As I write about, the clinical encounter is one of such deep vulnerability, of intimacy. When you're sick, you're kind of at your most raw, and then you trust your caregiver. And so what I tried to think about in the book is what work had to go into practice by these practitioners in order to be able to gain that trust, because it wasn't always granted to them just by virtue of the fact that they were physicians. They were constantly questioned in terms of their authority and their expertise, and often through the language of competence, which I talk about is just this coded, racialized discourse about you're not good enough. So how can you're not competent enough, when in fact, all of the metrics show that immigrant physicians have fewer malpractice suits than their US trained counterparts, and that patient satisfaction is often on par or greater than their US trained colleagues. So it's not that there actually was a differential, but there's this perceived differential. And so they had to do a lot of work, I think, in order to overcome these barriers that around what they actually could do and whether they had the expertise. And so they often reported spending a lot more time with their patients, figuring out different kinds of strategies for interaction. So even just walking into a room differently than their US trained counterparts might have to walk into, to be a little bit more prepared, to be a little bit more cautious, to develop different kinds of relationships so that they would actually be able to yield this therapeutic encounter. And, I think those are the subtle ways that we don't always pay attention to, that people have to, just change how they act in order to do the work that they are asked to do.
So in a moment, I want to talk about how foreign medical graduates, particularly from South Asia, sort of ascended as cultural figures, because I find that just incredibly fascinating. But let's stick with the early years of the program for a minute. We are going to end up at the Mindy Project. So did they get any help in integrating or in establishing themselves as a professional class? Was there any sort of political backing for them, or were they just kind of tossed out into rural areas and expected to make the best of it?
Yeah, I think that's pretty much it. I mean, the American Medical Association was at this time especially really and continues to be the most prominent organization for physicians. And they were not so keen to support immigrant physicians. I think part of the conversation at that time was that these physicians are sort of diluting the integrity of the profession. It reached an apex probably in the 1950s. If you look at the Gallup polls during that time, people trust physicians more than any other occupation in the United States. And then it slowly starts to diminish with, there's some medical mismanagement issues. There's the rise of political activism that's kind of challenging the authority and the expertise of physicians. And then you have these immigrant physicians who show up and who are claiming the same title, the same authority as their US trained counterparts. And I think that this is really a challenge to larger medical system. And so the AMA was not so supportive for quite some time. These physicians, they organized to try to have a special section that, for example, that was geared towards dealing with their specific issues that they had to contend with when they came to the United States. And they made this argument that, well, there's a women's section by this time, this is like in the 1970s and the 1980s, that are dealing with the unique kinds of issues that women face in the workplace. And so immigrant physicians, at that time they're called foreign medical graduates, should also have a particular kind of section that advocates for them, that helps them navigate the issues that they're experiencing as physicians. And ultimately, the American Medical Association said no, that if you want to actually be a part of the larger physician workforce, you should just be a physician and not, and deal with the issues that you have to deal with kind of on your own. It was very much an assimilationist model that they suggested was the way forward for these physicians. So I think they really didn't find support from what we call organized medicine or the medical establishment. And so I think they really turned inward and found community with each other to try to support one another, to share information, to advocate for one another, talk about, well, this hospital has a certain sympathetic, board, whereas another one might not. And these kinds of informal networks and information flows, I think, were really, really important in supporting the physicians, especially early on in their time in the United States.
Sort of a classic immigrant story of the community banding together for so many different ethnicities to support themselves, to support each other emotionally or logistically, and sometimes financially as well. It's a pattern that seems to get repeated again and again, justifiably, if the overarching, the dominant society isn't being as supportive as it should have been, even if it's invited these people to start with.
Yeah. Yeah, I think that that's exactly right. And part of what I found is that I think these physicians were a little bit surprised by that, because often they're elite, and they're elite from country of origin as well. And so I think there wasn't always that expectation that they would be treated in ways where people, they would apply for jobs and people would say, no, you're born in the wrong country, you can't apply for this job. Or they would be denied hospital privileges based on, records not being sent properly or things like that. And so that really, I think, complicated also their sense of identity a little bit. Where we were invited to fill this labor shortage, our entry was expedited, we're legal, that this is not some kind of clandestine migratory route that people are undergoing. And so yet, why is this still happening? And I think that was, a kind of conundrum that they dealt with.
You do raise the point in the book that precisely because, as you just said, these were elite medical graduates in their home societies, and also their home societies organized medical education differently when Indian medical schools were government funded, which meant that when those physicians arrived here, they weren't carrying the kind of educational debt that an American medical graduate might have. Did that turn out to be an issue? Was that a sore spot?
I think it ended up, it's a very complicated dynamic. It's the one of brain drain that is very difficult to figure out. So for sure, these physicians, they were trained in the most elite medical schools in country of origin. And the way that medical education is structured there is that they're government subsidized. The best medical schools are government subsidized medical schools. And so that means that they're taxpayer funded. And so people who are able to get into these medical schools often don't have to carry the kind of weight of debt. And so they're able to come to the United States and start earning. Granted, especially as a resident, it's not that much, but afterwards, it does become a significant amount. Even if they're working in primary care, it's not, it's still significant. And so they're able to accumulate this economic and financial capital. And that becomes really, really an important strategic tool for them, I think, later on, as you reference the later periods of kind of this political awakening that happened. I think having that base, that economic base, was very useful.
So you raised the issue of brain drain, and I want to be sure that we talk about that before we move on to the further success of this class of international medical graduates. This is a difficult problem. Right? I mean, here are people whom, as you've referenced, are the elite, the cream of their profession in their country of origin. They're being drawn to the United States because of the United States need, which means that their home country is being deprived of them. And the US may need them also, but surely their home country needs them more. And as I look at the history that you've written, people have been talking about this issue of brain drain for decades, and no one really seems to have fully faced up to the ethical conundrum within it, even though they've been discussing it for a long time. So what are your thoughts?
Yeah, it's like I said, it's a hard one because there are many different ethical conundrums at play. So one is exactly what you talked about, and it can be understood as a resource extraction model, that this is a neo-colonial dynamic where essentially this human capital, these people who are, absolutely necessary for the functioning of country of origin, are getting persuaded to come to the United States, and that this is creating this kind of imbalance of power where the US is attracting all of these important practitioners, and this country of origin, which in this case, India, Pakistan, who have very extreme need for physicians, are not able to meet that need as a result. Yes, that's there. But another problem is that part of the UN Declaration of Human Rights is that everybody has the right to movement. And we live in a society, or we should live in a society, in which that singular decision on anybody's part is absolutely their own singular decision and should not be disallowed. And so those are these two competing things. But on the one hand, you want to promote, as part of any liberal governance strategy, you want to promote freedom of movement. And on the other hand, you realize that freedom of movement is going to result in these kinds of imbalances. And so the way that I think about it is, how can we create different kinds of incentive structures? How can we think about reorganizing labor, whether that is in the United States or in country of origin, such that if people make the choice to leave, it doesn't have these dire consequences for the places that they have left from. So how do we think about overproduction? How do we think about all of these issues such that we realize that there is a deep connection, that we are, if COVID taught us anything, it's that we need to start thinking on the level of planetary health and not on the level of the nation state. So how do we think about coordinating strategies across borders such that we understand that health is something that needs to transcend those issues? And we have to start reorganizing such that maybe the physician is not the central locus anymore, and that, we think about community health workers and para professionals, as you talked about, who are supporting, and nurses and physician's assistants. And so I think we just have to start thinking creatively and differently so that we don't prevent people who want to move from moving, yet their movement doesn't completely decimate the places that they've left.
And of course, this is not only true for physicians, right? I remember a conversation in the United Kingdom a couple of years ago about how it appeared to be sucking nursing graduates out of sub-Saharan Africa, and in the same way, depriving those societies of their trained professionals who had been trained at that society's expense. And the conversation focused on, circled around the same issues you're voicing of, on the one hand, that home society really needs these people whom it trained. On the other hand, you cannot block people ethically from attempting to pursue opportunity, and
Right.
opportunity and a large enough salary to start sending money home is
Right.
available in the industrialized country more than it is in their home society. It was a bitter fight in the UK for a number of years. I want to go back to this question of how well these people did when they were allowed to come and when this program was created. And there is, I think, an irony in that as well, because these Indian medical graduates, they worked so hard, not at the jobs they were allowed to have. They faced down racism in the US. They built these internal networks, and they were incredibly financially successful.
Mhm.
And in many cases, it seems like they recapitulated the patterns of that other successful classes, not related to ethnicity, have followed, which is that they moved to where the money was. The standard immigrant pattern of the first generation, in the 19th century, it was the first generation lands in the inner city, and the second generation gets to move to the suburbs. Sounds like that was true for these medical graduates as well, which meant that though they were personally successful, they were leaving the under-resourced areas that they were supposed to have been helping. So how's that worked out?
Yeah, so this is, one of the conundrums of these last 60 years. Because if you look at the communities that are considered to be shortage area communities, it's been pretty consistent over these last 60 years. So you ask this question of, if people are constantly coming, why is it that these communities are still shortage area communities consistently? And it's exactly what you said. So after these physicians would come and complete their residencies or the terms of their visas, certain places, often they would leave and they would go to establish more lucrative careers elsewhere. They would want to start families elsewhere, where they also had other communities. So maybe they didn't want to stay in Tuscaloosa, Alabama, that felt like that wasn't a long-term possibility. And so they would leave. And we have this issue now where, I live in Boston. I don't have a physician shortage issue. I have a surplus issue here. And so this is one of the I think language really matters, because we talk about, there's a physician shortage, but that's not true. That's uneven. There's a physician shortage alongside surplus in the United States. And we have an issue of distribution that is really, I think, a central dilemma that hasn't quite been resolved yet. And so what happens is that often, these practitioners, they do great work for the period that they're there, but it's hard. It's under-resourced, it's unpredictable. They're in environments where, especially lately, it's even more unpredictable. They're in environments where, maybe they're not socially or culturally as comfortable as they would like to be. And so they make choices to exit those communities, and then there's a gap. And in their place come the next round of immigrant physicians to fill that slot. And this is just continually what happens, and what has happened for the last 60 years in this country.
Has there been, as a result, have there been any proposals to change the way the U.S. treats who are now called international medical graduates? Has this program been questioned at all, or is it assumed that we still need them in those under-resourced areas, and therefore we're going to continue to open the door to people who are trained elsewhere?
Yeah, I think that the shortages continue to be present, and especially in primary care specialties. So in family medicine, pediatrics, internal medicine, which is the front line of healthcare. And those are the specialties that also are the least well compensated in the grand scheme of things. And they're the ones where US trained physicians don't want to necessarily specialize. And so we have these gaps that continue to be in place. And these immigrant physicians come to fill these specialty gaps, and especially these specialty gaps in these communities. And I don't see this changing anytime in the future, unfortunately.
So one of the folks who's watching asks a question that I think is a very reasonable question to ask at this point, which has been, have changing political attitudes toward immigration had any impact on this flow of needed physicians?
Yeah, I mean, I think we're starting to see the impact of these things. So, the H-1B visa issue, which the H-1B visa is one of the visas that immigrant physicians use in order to come to the United States.
Hmm.
And September 19th, the Trump administration issued an executive order changing the visa sponsorship fee that employers have to pay. So initially, the fee for hospitals was generally between $2,000 to $5,000 per visa applicant,
Mhm.
and that has increased to $100,000 per visa applicant that these hospitals will have to furnish. And so, okay, maybe that's something that, well, wealthier hospitals often have US trained medical graduates, so they don't have to deal with this as a cost.
Mhm.
But especially in rural communities where about 40% of the physicians are on H-1B visas, for a hospital that may have 10 immigrant physicians staffing their facilities, all of a sudden the fees that they have to pay out have increased from 20 to 50,000 to $1 million
Mm.
generally
Mhm.
per year. And that combined with the additional Medicare cuts from the budget bill that was passed, already there's so much pressure on these hospitals. They're operating razor thin margins. And now, when you add this question of being able to actually do visa sponsorship fees, I think the consequence is going to be, so if you had 10 physicians before, you'll have 5 now. And distributing the work across 5 people is going to be, I mean, it's just going to be a lot harder on the physicians in terms of burnout. It's going to be a lot harder on the patients in terms of longer wait times. And, just generally, they will not have access to the practitioners that they need. So I think that, we'll see the consequences of these kinds of unpredictable, erratic immigration policies. The American Medical Association is trying to get some kind of exemption from the administration for these physicians, and it has yet to be determined whether they will be exempt from this fee or not. But this is part of the problem: is that people's healthcare is now being, it's they're waiting. It's in limbo because maybe there will be an exemption, maybe there won't be an exemption. How long will that exemption actually last? These kinds of uncertainties. I mean, the consequences are going to be for the population that is being served first and foremost. And I think that's a very, very dangerous place to be. So that is generally causing a lot of angst, I think. And in addition, I mean, just with the rise of xenophobia and racism in this country, I think people are going to start to make different choices. The UK, Canada, Australia, these are still places that, not perfect, lots of issues there, but they still have more predictable, consistent immigration policies. The rise in hate crimes, there have been in all of these places, but there are no guns, or there are fewer guns. And I think that these kinds of things are going to enter into people's decision-making calculus. And so July 1st, which is a really important day for the medical system, I think we'll start to see the consequences of these things. If there are fewer people who are willing to apply to come to the United States, fewer people who are going to fill those slots. I think we're in this waiting period right now to see what exactly the consequences of these immigration actions are going to be.
I'm so glad you framed that around the discussion of the visa fee, because I think for many Americans, if they have heard of the H-1B visa at all, they tend to associate it with Silicon Valley and bringing in engineers rather than posing the possibility that it would decimate rural medical care. And that's a really important part of the conversation around that. So thank you. So let us end with something a little more positive, which is I am fascinated by the way in which, from 1965, with this movement of foreign medical graduates, particularly South Asians, into the US, that culturally a South Asian physician became a figure of authority. And you reference in the book both the first generation, people like Deepak Chopra, to the very prominent South Asian physicians who are actually the children of that
Mhm.
immigrant generation, like Surgeon General Vivek Murthy, Sanjay Gupta on CNN. And so and then we'll get to the Mindy Project, but I just would love to hear you reflect for a minute on how that, on what it meant that the South Asian physician becomes like, to reference 1950s American medicine, the Marcus Welby of the 21st century.
Yeah, I think it's a really interesting story, and the way that I tell it is that I think this kind of economic capital was really, really useful. And these physicians started to understand that they could use that capital in order to gain political capital. So one of the things that social scientists we think about is how is it that different forms of capital, you can convert one to the other. And so this economic capital was converted into this kind of political capital where they really started to understand their position, that they could influence politics, that if they organized, if they had a strong enough collectivity, that they could start to influence political politicians and their kinds of legislative choices that they were making. And so what happened was that these physicians, they started to talk to people like Daniel Moynihan, who was very powerful at that time, Jim Bates, Stephen Solars, who all of these were Congress people, and they started to explain to them what they were experiencing within the workforce. They were saying, we are experiencing this kind of discrimination, and we need your assistance in doing a few things. One is making sure that immigrant physicians had all sorts of complicated routes and tests and additional paperwork that they had to fill in order to actually get licenses and do the work that they were doing. And many times they were frustrated because people would say, well, we're not getting the jobs that we want because people are saying that our paperwork isn't appropriate or that we take different tests. And so they really lobbied for these Congress people to put into place some kind of legislation where they would have the exact same tests as their US trained counterparts, so that this was at least one way where you couldn't say you're better or worse than the US trained counterparts, that at least this was some kind of equalizing force. And so I think they used that, and over time, then there was this familiarity with this figure. So you had this just demographic numbers of, now you have people who are coming and doing this work for a long period of time and who are present within these clinical spaces. You have them kind of politically mobilizing, getting this acumen and understanding of how the US system works. And then you have these few prominent figures, I think, who really kind of take this whole migration into mainstream space. So when somebody like Deepak Chopra gets called up by Oprah, that's huge for the whole South Asian physician community, because it's this kind of public validation of this figure. And I think that carried a lot of important cultural weight. And then you had other figures who also ascended to the scene. And eventually there's this proliferation that we start to see where, in this particular form, the South Asian physician, often South Asian physician who's a man. So we also, I want to add like Ashish Jha who is the COVID White House coordinator, to this picture, that they're able to emerge as these voices of national health on this public scene. And one of the interesting things is that while other non-white men during this period of time are deemed the terror figure and the threatening figure, that I think that there's something about the kind of care work that these practitioners were providing that really mitigated their foreignness, such that they could ascend in this particular form into these spaces of public media. And then we have Mindy, who comes at the end of that line,
which is delightful. That now we should be clear to say that the actual actress, comedian, producer is not herself a physician, but she writes a character who is a South Asian woman who's a specialist physician. And do I have this right? She is the first lead South Asian character in a scripted TV program of either gender.
Yes, that's absolutely right. And so I think it just speaks so much to the ways that, and for 6 seasons, so not even for one season, So I think that you need in order for any TV show to be successful, it has to be relatable. You have to have some kind of figure that the audience has some familiarity with, And so then you ask this question of how is it that this figure is such that the audience feels like they can relate to it? So how has this figure become ubiquitous enough, popular enough that one doesn't even bat an eyelash when you see this confluence of, okay, a South Asian practitioner as, the lead in a show. And I think also that has to do with, for 20 years before that, there was always a non-white physician, generally I would say South Asian, who's delivering the bad news in a, medical drama, but they recede into the background. They end up not really being main characters, but they're always present. And I think all of that work, and of course they are larger roles, ER, et cetera, they're more prominent roles. But I think that all of this work, what it does is that it reinforces this particular configuration in our social imagination so that this figure is familiar and this figure is ubiquitous and just so much a part of the everyday existence of the US, just not even healthcare system, but mediascape.
So we have just about 2 minutes left. So I just want to ask you to close out. Where do you see this going? Is there going to be clearly the need in the United States is still there, but do you see any sort of rapprochement on the international stage? Any interest in compensating countries for this brain drain? Any sense of something being owed to these home societies? Is there any kind of, I guess, transformation of thinking about this in the offing?
I don't think so. So in 2010, the WHO issued this program for thinking about international recruitment of health professionals and best practices around how that should be done. And they really urged, especially wealthier countries, to pay more attention to these kinds of dynamics and to rethink their domestic infrastructure so that it wouldn't be so reliant on healthcare workers from elsewhere. But I think at the end of the day, we have to really consider this question that we were talking about already of is this a planetary health issue? How can we think about redistribution, not just in the United States, but how can we think about it on a planetary scale? And how can we reimagine what care looks like and really use the kinds of resources and the kinds of knowledges that local communities also have, such that we can really start to help people, I think, all over the world.
Thank you for those final comments. And thank you for this great discussion. I enjoyed your book so much. It's a fascinating history. And we're now going to tell people where to find it. But thank you for coming on to talk to us.
Thank you so much.
So that is it for this installment of the Health Storytelling Author Q&A series. Please consider following Dr. Alam on social media. She has accounts on LinkedIn and on Blue Sky. And buy her book. It's available at her publisher, Johns Hopkins University Press. You can buy it at Amazon if you have to, but we prefer to recommend bookshop.org. It's the anti-Amazon. It funnels orders to independent bookstores. It's well worth supporting. And with that, this concludes our fall season in the 2025-2026 Health Storytelling series. We will have a great new set of authors lined up for the spring, and we will reveal them in early January. To find out who will be appearing, please keep an eye on the RSVP page that you probably used to come to this event tonight. Until we announce them and until we start streaming again in January, I'm Maryn McKenna. On behalf of the Center for the Study of Human Health at Emory University, the Georgia Center for the Book, Emory's Center for Public Scholarship and Engagement, Ideas Festival Emory, and from me, thank you for watching. See you in the new year.